lecture today, you guys. Lower extremity physiologic testing. You guys are gonna be excited. All right. So,
I hate doing those ABIs.
well, it's much more than ABIs.
I know, but that photos.
Yeah. So here are objectives. So we're gonna learn about the goals of this indirect testing. We're gonna learn all the different indirect testing methods, advantages, disadvantages, how to prep your patient, what the normal waveforms are gonna look like. We're gonna do some case studies, and exercise stress testing, which is fun. Okay, so the goals of physiologic testing are to see if there is some sort of arterial disease, and to rule out if that's what's causing the patient's symptoms. Because some patients might have neuropathy on top of an arterial obstruction, that could be causing their symptoms. So segmental pressures kind of help predict if the patient has adequate perfusion to help heal ulcerations and wounds. This is also useful in assessing limb perfusion to see if it's increasing or decreasing in serial follow-up exams. And that's useful when there's no intervention done. It just helps monitor the effects of more conservative management, like smoking cessation, exercise, and reduction in cholesterol levels. So that's kind of a brief overview of why we're doing it. So there's some advantages to this kind of testing, and there's also disadvantages. Pros, it's simple, there's a small learning curve, there's a short test time to perform it, although the segmentals can kind of take some time, like sometimes it's really tedious. But for the most part, like an ABI is a quick, simple way to see if there's any kind of disease. It's accurate for hemodynamically significant disease. So you get objective, quantitative info from these tests. It's cheaper than buying an ultrasound machine. Normal results at rest and post-exercise rule out hemodynamically significant disease. It's got high sensitivity and specificity for detecting symptomatic atherosclerotic disease. Okay, so the cons to physiologic testing, the biggest one is that you can't determine the exact location of disease. It just gives you a region. It just tells you kind of like the general area where the disease is located and the general severity of the disease, but it's not specific. Also, it doesn't detect mild disease. It really only is advantageous for severe disease. So some methods of indirect testing are segmental pressures, such as ABIs, segmentals where you'll have cuffs along the leg. We'll get into that in a minute. Plethysmography, which we've already talked about in upper arterioles. So that includes PVRs, photoplethysmography. And so with segmental limb pressures, we're going to learn how to calculate ABIs and co-radial index. You can also do Doppler, continuous wave, analog waveform analysis, and exercise stress testing. Okay, so we've kind of already gone over this last class, but really we need to learn about the patient's symptoms before we do the test, know where the pain is, which leg is worse, how long does it take for the symptoms to go away, what are the risk factors for this patient? Are they high risk because they're diabetic? Are they a smoker? Do they have coronary artery disease? So these are all things that you need to know before going into the test so that you kind of have an idea of what to expect. And quickly to go over patient physical exam, you're looking for anything like trophic changes like thickened nails, shiny skin, hair loss, cold feet. remember. These are all things that we talked about last class as well, so we're not gonna spend too much time. Also, you might wanna quickly palpate a pulse, either, in the groin or the popliteal fossa. Usually you can get, pulse palpation on PTAs. Okay, so this is an outline of segmental pressures. And these are all the steps that you're gonna take, when you're doing this test. So first you're gonna prep your patient, you're gonna decide if it's a 3 cuff or a 4 cuff. Usually that comes with the order. So you're gonna apply the cuffs, you're gonna get bilateral arm pressures, and you're gonna get pressures in the legs. You can also use PPG, photoplethysmography for that. And then you're gonna calculate the ABI. That ABI is gonna determine whether or not you move on to the next step to get the segmental pressures in the legs. And then last thing you're gonna do is get the toe pressures, and then you're going to interpret your findings. And we're gonna talk about all of this as well. Okay, so segmental systolic limb pressures. So basically you're comparing the limb blood pressure to the brachial pressures. We're getting systolic pressures only. The limb pressures in the legs should be greater than or equal to the brachial pressures in normal patients. If you see a greater than or equal to 20 millimeters of mercury difference in the pressure between adjacent cuffs, like cuffs right next to each other on the same leg, or if you see a pressure difference horizontally at the same level on both legs, so let's say like you have a thigh pressure difference on one leg versus another, that's going to indicate that there is some disease present. Okay, so setting up your patient. The patients should be supine for 5 to 10 minutes before you start this test, because you want to make sure that their blood pressure comes down and you're eliminating effects of hydrostatic pressure. So you're going to apply the cuffs to the arms and legs. Legs should be relaxed and slightly rotated outwards, and the patient's just kind of overall relaxed. Then you're going to determine the blood pressure cuff size, and this is going to be determined by whether it's a 3 cuff or a 4 cuff test that you're performing. So basically the arterial cuff bladder size needs to be 20% wider than the limb diameter of your patient. Or it should be 40% of the limb circumference to get an accurate pressure determination. The bladder is the part of the cuff that fills up with air. So this is your bladder, and so that's the length that I'm talking about here. So for example, like the thigh cuff, you want 17 or 18 centimeter bladder width by 36 centimeters in length. So the bladder is going to be 36 centimeters long for that 12 cuff centimeter width. In patients with kind of big arms, you're going to use a 12 centimeter cuff for the arms. For pediatric patients or with patients who have really small arms, you can use a smaller cuff, like an 8 centimeter cuff. Metatarsal cuffs are optional. I've never actually seen anyone use metatarsal cuffs. So it's kind of like you wrap it around the foot, like around the dorsal area of the foot. I've never seen that done, but definitely digit cuffs. For sure, we're going to use those. So there's a 3 cuff method and a 4 cuff method. The 3 cuff method uses one large 17 centimeter cuff around the thigh, plus a calf and an ankle cuff. The 4 cuff method, it uses 2 smaller thigh cuffs, so they're both 12 centimeters, and one's a high thigh and low thigh, as well as the calf and ankle cuff. So the 4 cuff method is better at differentiating inflow disease, which is aortoiliac disease, from superficial femoral artery disease. Most automated systems these days use the 4-cuff method. When you're applying these cuffs, you want to make sure that the cuff is snug so that it's not loose. You want to make sure you can't slide a finger under there. You really want it snug to get an accurate blood pressure determination. Okay. A couple of tips when you're applying the cuffs. You're going to raise the patients like yourself. Don't let the patient help you by lifting their leg, because when you apply the cuff and they relax their leg, when it goes down, the cuff is going to be super loose. So don't let them help you lift their leg. So when you're placing the cuffs, you're going to put the bladder on the posterior medial side of the limb, so kind of like the inner thigh towards the posterior side. And then you're going to bring the cuff one full wrap around the leg, pull it up and across the leg to tighten it to make sure it's really snug. You can put cuffs over thin clothes. That's not going to really affect the pressure determination. Make sure you put the calf below all the bones of the knee. If you don't do that and you're putting it over all those bones, you're going to get artificially inflated pressures. So just make sure you put the cuff distal to all those parts. So a lot of these patients you get might have a lot of open wounds and stuff, and doctors still want you to do the ABIs. If you can, or if your department has it, put some plastic wrap over those wounds, because they're probably going to be oozing, and it's not pretty, and it's also probably painful for the patient too. Some systems will require a certain size for the arm cuffs, either a 10 to 12 centimeter cuff, and that's just based on each system. Okay, so let's talk a little bit further about the 3-cuff technique. So like I said, you're going to use one large thigh cuff. The thigh pressure should equal the brachial pressure in normal patients. An abnormal pressure will be 20 to 30 millimeters of mercury less than the brachial pressure. So that's going to indicate disease. It can be proximal, like in the aortoiliac area, or it can be under the cuff in the common femoral artery or the SFA. But you won't know where the disease actually is with the 3-cuff method, because you can't differentiate where it's coming from. So a technical note here, most modern systems have kind of weak air pumps, and they can't adequately inflate this really big 17 or 18 centimeter cuff for the thigh pressures, because that air volume that's required is way larger than the 12 centimeter cuff, and it takes a really long time to inflate it, and it's really painful for the patient as well. So a lot of patients can't tolerate that large thigh cuff being inflated. So you're just going to have to take it case by case. PVRs are okay to do, but most manufacturers kind of promote the use of the 4-cuff method for this reason, because it takes so long to inflate this really big cuff. So that's a drawback for the 3-cuff technique. You can't really identify the region of disease. So for the 4-cuff technique, it's better at identifying the region of disease. It can differentiate between aortoiliac inflow disease versus femoral disease. So a normal high thigh pressure, so that would be this one, the most proximal cuff, is 30 millimeters of mercury over the brachial pressure. Pressures of 30 millimeters of mercury lower than the brachial pressure is significant for disease. So with these high thigh cuffs, there's gonna be some sort of artifact. So what that means is like the cuff is kind of narrow compared to the girth of the patient's limb, like how big it is circumferentially. And so that's gonna create a pressure artifact that raises the thigh pressure at least 20 to 30 millimeters of mercury over the systolic pressure. So it's gonna be way over the systolic pressure. So just be aware that it's gonna be high. Okay. So the next step is to get your bilateral brachial pressures. So you're gonna use continuous wave Doppler over the radial artery, as you can see here in this picture. That's the preferred method. You can also use the brachial artery, that's a little bit more difficult. So you're gonna try and find the strongest signal by sweeping across the entire artery and then back to the center to find the loudest signal that you can. So you're gonna hold the probe close to the base, support the transducer so that you're not sliding around and losing the signal when you inflate the cuff. The next thing you're gonna do is inflate the cuff until you can't hear the signal, and then you're gonna keep inflating from that point 15 to 20 millimeters of mercury more. And once you get up to that pressure, you're going to bleed down the pressure slowly, so you're gonna slowly release it, and then you're gonna note the pressure when you hear the signal return. And that's gonna be your systolic pressure. You can only get systolic pressures with a continuous wave Doppler. You're not gonna be able to get the diastolic number. And we only need the systolic number anyway. So you're gonna do that for both arms, get your systolic pressure. We're gonna use the higher of the two arm pressures to calculate the ABI. And if you guys remember from the upper extremity arterial lectures, greater than 20 millimeter mercury pressure difference between both arms indicates that there's some sort of subclavian stenosis or occlusion going on. Also, another note, don't take a pressure in an arm that has a dialysis graft or a shunt. Very important. Okay, so the next step is to get the ankle pressures. So again, you're gonna use continuous wave Doppler, and you're gonna get pressures from the posterior tibial and the dorsalis pedis on both legs. The dorsalis pedis can be kind of hard to find. So if you're having trouble finding it, try finding a branch between the tendons of the big toe and the second toe. Otherwise, if you can't find it, just use the PTA. That's fine too. So you're gonna inflate the cuff, 20 millimeters of mercury over the occlusive pressure. So once you stop hearing that signal, keep going 20 millimeters of mercury more. And then you're gonna slowly bleed down the pressure until you hear the signal come back. And the first returning pulse is the systolic pressure for that segment. Okay. Some tips when you're trying to Doppler the posterior tibial. So you want to make sure to angle the probe at least 45 to 60 degrees, like angle it towards the patient's head so that you get a good angle. You do not want to be 90 degrees to the vessel, like in this image here. Also, don't position the probe too far distal to the medial malleolus, like you're doing here, because you're not actually getting the PTA at this point. You're getting like some branches off the PTA. So to make sure you don't do that, find a bone, and you want to be as close to that bone as possible. You don't drift too far towards the heel. Okay. So the most common errors when you're trying to get pressures with the PTA in this way is that sometimes your probe will drift while you're getting while you're in the suprasystolic phase, so like when you're not hearing the signal because you're over the systolic pressure. And then once you start bleeding down, sonographers usually kind of like try to find the signal again. You might miss the actual signal. So just kind of be aware of that. Also, these are really small arteries, so if you have a heavy hand, you could actually be compressing that artery and obliterating the signal. And so like, if you're bleeding down the pressure and you don't hear anything, and then you suddenly hear something because you let up on that pressure, you're probably missing the actual systolic pressure because you were pressing down too hard. So during cuff inflation, there's a closing pressure and there's an opening pressure. So the closing pressure happens during inflation, and that's the point when you're inflating the cuff and you stop hearing the pulse. That's the closing pressure. So during pressure bleed down, when you're decreasing the pressure in the cuff, the opening pressure is when the signal reappears. And the opening and the closing pressure should be kind of close to each other. So if you're getting an opening pressure and a closing pressure that are way off from each other, you probably miss the actual systolic pressure at some point. So reassess.
When you say close together, do you mean sequentially or like the
Like,
numbers are similar?
The number, the systolic number that you're getting, those should be kind of close together. So when you stop hearing the pressure when you're inflating the cuff, take note of that pressure. And so when you bleed the cuff, the pressure should be around the same as the opening pressure, as the closing pressure. Does that make sense?
Mm-hmm.
It's just kind of a way to know like a ballpark of where that closing pressure should be.
Are you saying that assuming you're not using a machine that's recording that? Cause like the machines that they take these pressures on it, you can see like when it flatlines, that's recorded, and then whenever the waveform starts.
Yes, that's PVR. That's PVR, that's pulse volume. So this is just simply getting the pressures, not like any waveforms or anything like that. I understand what you mean. So this is just like if you have like a handheld Doppler and you're getting like a simple ABI.
Okay.
There isn't like a recording, like tracing that you can use to help you. This is just simply listening to it, to the pressure. Does that make sense? Okay. So, the American Heart Association has a recommended sequence that they want you to do ABIs in. I've never actually seen anyone do it this way, but. So you're gonna start at the right arm, get the right arm pressure, then go down to the PTA, and then the DPA. And then you're gonna jump over to the left PTA, get the left DPA, and then get the left arm pressure. And once you do that, you're gonna go back to the right arm to repeat the pressure. So, if you see a difference between the two right arm measurements from the first measurement that you get to the last measurement, if it's greater than 10 millimeters of mercury, you're gonna wanna use the second arm pressure, the one that you're repeating.
Does it matter if it's 10 up or 10 down?
It just, greater than 10. Well, I guess it doesn't matter
Yeah,
if
either
it's 10
way.
up or 10 down, it's just
Okay.
more than 10 millimeters difference. So you're gonna use the higher brachial pressure to calculate the ABI. So the logic here is that systolic pressures like might drop during ABI acquisition. And so it can cause like an artificial pressure gradient between the arm and the ankle. And that would cause an abnormal ABI. So you wanna, I guess, limit that by taking the right arm pressure and then doing the ankle so that there's not that much pressure. And this is just strictly for ABI, so you're just getting the arm pressures and then the ankle pressures, and that's it. Okay. talked about this for upper arterioles. You can get digit pressures, the toe pressures with PPG, photoplethysmography. And so that's, it consists of an infrared light source, a flow sensor or a photocell, and the photocell receives the reflected backscattered infrared light, and it measures that reflected light. So it's going to detect all the cutaneous flow beneath the skin, and it's going to record those pulsations. The amount of flow determines the amplitude of the waveform, so how high this waveform gets. It's easier than using Doppler for the digits. So you put a cuff on the digit and you inflate it proximal to the PPG sensor. So you're going to have a cuff at the base of the toe, and then you're going to put your PPG sensor at the tip of your toe, like right around the toenail. So the cuff on the digit, you're going to inflate it, and it's going to obliterate the baseline PPG tracing. So once you inflate your cuff here, this tracing is basically going to flatline. And then you're going to bleed down the pressure, and so you're going to see your pulse return. And so that first pulse return is your systolic pressure. And then you're just going to record that pressure for the toe. Okay. So with the PPG, you can definitely get a lot of noise artifact. So you want to make sure to not mistake like random noise for the actual returning signal. So the PPG sensor is sensitive to light, so you want to make sure to cover the sensor, cover the foot, the toe, with a dark towel or something that you have available to kind of reduce the interference of the ambient light. So with PPGs, there's no audible signal like there is with Doppler, so you're strictly relying on seeing the return of this waveform. So this image here on the left, you have the baseline waveform, they inflate the cuff, bleed down the pressure, and then you see the return of the pulse right here, this tiny little blip here, and that's where they're going to record that systolic pressure. Over here on the right, you kind of have this noise artifact, and then the flat line, and then the return of the signal. So you just kind of have to like see that the pulse actually returns distal to that initial pulse return. If that makes sense. Like this is all just noise. Like these are random. They don't even look like pulses. So that's just artifact. So don't measure the artifact. Okay. So some of the pros of getting pressures with PPG, you can do it bilaterally, simultaneously, both sides. It's convenient. It doesn't require a lot of skill. However, the cons, it's more difficult to interpret the returning pressure point because of, you can have the ambient light interference. There's no audio output, so you're simply relying on that waveform to come back. So you can't hear the pulse return. It's not great for severe disease because toe perfusion and PPG pulses will disappear or flatline with severe disease, so a lot of times you won't even get a baseline tracing. With Doppler, the pedal pulses, you'll still be able to get them even with severe disease, up to a certain point. Pros for using Doppler instead of PPG, you can see the Doppler signal, you can hear the Doppler signal. You can usually detect pedal Doppler signals even if the toe PPG pulse is undetectable. So like if you're getting a flatline tracing with PPG, you might still be able to pick it up with continuous wave Doppler. Doppler is also more sensitive than PPG in low flow and low pressure situations. toe pressures, is to calculate your ABI. If your ABI is normal bilaterally, you don't need to get additional segmental limb pressures. So you don't need, if these are normal here at the ankles, you don't need to get the thigh pressures or the calf pressures, because those are gonna be normal too, right? So to calculate your ABI, you're going to divide each ankle pressure by the higher of the two brachial pressures. If the pressures, if you got both the PTA and the DPA, you're gonna report the higher of the two for the ABIs for each ankle. So whichever one's higher, the PTA or the DP, report the highest one. If you're using an ABI as a marker for cardiovascular disease in general, you're gonna report the lowest ABI for each ankle. And so the thought behind that is that if you have an ABI value that's less than 0.9, that patient is twice as likely to have prevalent coronary heart disease. So an ABI less than 0.9 has a 2 times higher likelihood of having heart disease. Okay. So if the ABI in that scenario was abnormal, this is your next step. You're gonna get segmental pressures. So you're gonna get pressures in the thigh and in the calf. The thigh pressures are super uncomfortable for the patients, and I always hated getting the thigh cuff pressures because they would always complain about how painful it was. So you may or may not be successful in obtaining the thigh pressures dependent on the patient. So you wanna make sure that the cuffs are snug because you wanna get this right the first time. You don't wanna do it more than once. You're gonna start at the ankle and work your way up sequentially. But we've already done the ankle, so we're gonna start with the calf, then go up to the thigh. Try to be quick, because it does hurt. Patient might be able to tolerate it. If they ask you to stop, then just stop and just note that patient is not able to tolerate thigh pressures. I don't like hurting patients, so if they ask me to stop, then I'm gonna stop. Okay, so at the calf, you're gonna position your continuous wave Doppler at the PTA. You're gonna inflate the calf cuff and get the pressure. The pressure that you're measuring at each cuff level is the pressure in the artery segment under the cuff. Even though you're Doppling the PTA, you're getting the pressure from under the cuff. So thigh measurements, if the calf and the ankle were both normal, you can skip the thigh. You don't need to do the thigh, because it's gonna be normal too, so there's no reason to like put the patient through that. So in the forecuff technique, the low thigh cuff, this one here, should be positioned right up against the upper thigh cuff and not too low so that it's right up on the knee, because that's uncomfortable for the patient and it might elevate your blood pressures artificially. So you're gonna inflate the thigh cuffs to 20 millimeters of mercury above the systolic pressure. And then you're gonna bleed the pressure down. You're gonna record your systolic pressures. The high thigh cuff, you might have to inflate it to 40 millimeters of mercury above the arm pressure. And that's just because of that high thigh artifact, because of the cuff width and the limb curve. So it's gonna have that thigh artifact. Okay, toe pressures. This is really good for small vessel disease. Really good to use in diabetic patients who have non-compressible vessels that you're able to get an ABI on. Like I said before, you're gonna cuff on the toe, the base of the toe, and then your PPG sensor right at the tip of the toe, right over the tibia. You're gonna inflate and then bleed for systolic pressures. So, to calculate the toe brachial index, you're gonna divide each toe pressure by the higher brachial pressure. Always by the higher brachial pressure. There's a lot of variation in abnormal TBI values, but generally, a normal value is gonna be greater than 0.75. And anything less than 0.66 or 0.6 is abnormal. So those are the two values that we're gonna go by. And so these are the resting ABI values that are really important for you to memorize. You'll probably see these on the test. A value of greater than 1.35 means that this is a non-compressible vessel. It's calcified, you know, like in someone who has diabetes or a smoker or something like that, some sort of scenario that way. 1.35 non-compressible, so that ABI doesn't really give you any value. An ABI value of 1.0 is considered normal. 0.9 to 1 can indicate mild, minimal disease, but we can really consider that value normal. When we get down to 0.8 to 0.9, that's going to indicate mild disease. Anywhere between 0.5 to 0.8 is moderate disease, and at this point, you're going to have claudication in these patients. Anything less than 0.5 is severe ischemic disease. This is where the patient's going to start having ischemic rest pain. They're going to be at risk for gangrene and tissue necrosis. So anything less than 0.5 is severe. Okay. Some exceptions for these ABI values. If the brachiosystolic pressure is under 100 or over 200, the ankle pressures might be 25% lower than the brachial pressure in a normal patient. So just keep that in mind. Okay, so now we're gonna move to interpretation. You've gotten all this data, now it's time to put it all together. If you see a gradient of 20 millimeters of mercury or more in the arm pressures, that could indicate subclavian disease. For segmental limb pressure interpretation, you want to compare one side to the other side. You want to compare the adjacent segments, like high thigh to low thigh. You want to compare the leg segments to the brachials, obviously. A greater than 30 millimeter of mercury pressure decrease between segments is significant for disease. Okay, so in conclusion, segmental limb pressures are useful in identifying the regions of disease. Toe pressures are useful when you have those calcified vessels that are non-compressible. Okay, so in this scenario here, this patient has a normal ABI on the right side. The brachial pressure on the right is 137, left is 143. You can see how the high thigh pressure is significantly higher than the brachial pressure. That's because of that thigh cuff artifact. But that's normal, that's what you want to see. The ABI on the left side though is abnormal. And the upper thigh pressure is 147. So that is automatically lower than the contralateral side, so that tells us that there's something going on there already. So it's likely that this patient has iliac disease on the left side. And so you see a drop here between these two contiguous segments. So 147 to 90, that's a pretty significant drop. It's like 15 or so. And that's gonna indicate that there's some sort of superficial femoral artery disease in this segment here. So compare the right side to the left side, and then you're gonna compare these contiguous segments to each other. And then lastly, the ABI is abnormal. So there's disease on the left side of this head. Any questions? Okay, so 3-cuff versus 4-cuff technique. The normal values for 3 cuffs, the ortoiliac segmentals are equal to or higher than the brachials. Normal thigh pressures rule out aortoiliac inflow disease. So if you have a normal thigh pressure, there's probably minimal AI disease. Abnormal thigh pressures, though, can be due to aortoiliac disease or femoral disease. 3-cuff method cannot differentiate the difference between the two. A 30 millimeter of mercury drop or more is positive for a hemodynamically significant stenosis, which is a greater than 60% diameter reduction. For a 4-cuff method, the high thigh needs to be at least 20 millimeters of mercury above the brachial because of that high thigh cuff artifact. Sometimes the thigh cuff artifact, though, can be eliminated in people with smaller legs. So in those cases, it'll be equal to or near the brachial pressure. But definitely, if it's below the brachial pressure, that's abnormal. The thigh pressure, yeah, less than the brachial pressure is abnormal, and that's going to suggest inflow disease in the high thigh cuff. A pressure gradient of 30 millimeters of mercury or more between the high thigh and the low thigh will indicate femoral disease. Okay, so there were some studies that were done, and they showed that a normal high thigh pressure rules out significant inflow disease with a 100% negative predictive value. And that just means that those patients who have a negative test result don't actually have the disease, so it's a valid test. An abnormal high thigh pressure, though, predicts significant inflow disease, according to this one study. Other studies have shown that the low high thigh value can be due to superficial femoral disease and not necessarily inflow obstruction. So the negative predictive value was high in these studies. So like if the high thigh pressure was normal, there's no significant inflow disease. But the positive predictive value was low for inflow disease, so it could be aortoiliac disease or it could be femoral artery disease. Okay, so some tips for interpretation. The bottom line is if the upper thigh pressures are normal for the 3 and the 4 cuff technique, there is no significant inflow disease. If the upper thigh pressures are abnormal for the 3 or the 4 cuff technique, you need to get waveforms in the form of continuous wave Doppler or PVRs to differentiate between inflow and femoral artery disease. So this is just going to give you a region, so we need to do additional testing to find the specific site of disease. So sometimes you can have a normal ABI, but a segmental pressure gradient, like from high thigh to low thigh, but the ABI is normal. So the book says you shouldn't interpret it as evidence for occlusive disease if the ABI is normal. Like most indirect methods, segmental pressures cannot distinguish between a stenosis and a total occlusion, or the exact location of that occlusion. So you're gonna need follow-up tests to determine that. Again, be aware that you're going to see a high thigh cuff artifact, at least 20 millimeters of mercury over the brachial pressure. And last thing is that ankle pressures can quantify the severity of ischemia. So pressure that's less than 50 millimeters of mercury is associated with ischemic rest pain. And at that pressure, foot lesions are less likely to heal. So you see a pressure that low, that's severe. So, limitations of getting segmental pressures, kind of talked about it a little bit, is calcified arteries. That's gonna limit you in getting these pressures in the ankles and other areas. So the cuff pressure won't be able to like completely obliterate the pulse. So you'll pump up the cuff to like over 200, 250, and you're still hearing the pulse. Rule of thumb is if you get the systolic pressure up to 250 and you're still hearing the pulse, that's not compressive. It's just not gonna be accurate. You're not gonna get readings. It's gonna be extremely high.
Patient's gonna be screaming.
Patients also will be screaming. Yeah, it's not comfortable for anyone. So, yeah, that's a limitation there. So if you're continuing to inflate the cuff and you're still hearing that pulse above 250, I would just stop at that and just call it non-compressible, because you're not gonna obliterate that signal. So, in general, the ankle cuff should be inflated to 30 to 40 millimeters of mercury above the brachial pressure and then bled down. In hypertensive patients, which you will probably encounter a lot, you're gonna require a higher pressure than normal to obliterate that signal in the ankles, because their pressure is already so high. So that increased inflation pressure is required to stop the flow, but that should not be misinterpreted as calcified vessels. If you see that the brachial systolic pressure is high, expect the ankle pressures to be equally high, if not higher. And that doesn't mean that that patient has calcified vessels, it's just that they have really high blood pressure. You can rely on a low pressure reading to be accurate, but you can't rely on a high pressure reading to be accurate because of the calcified arteries. So this is gonna require other methods like pulse volume recording, Doppler waveforms, toe pressures, to really assess lymph perfusion in these cases. According to the American Heart Association, the digital vessels in the toes rarely develop calcification. So that's a more accurate way to determine perfusion. So you're gonna have some clues as to whether these arteries are calcified. First off, non-compressible artery. Pressures are unobtainable. You can't obliterate the signal, that's your first clue. Or if you do get a blood pressure somehow, if the ABI you calculate is over 1.35, it's non-compressible. it's calcified. High pressures in the limb distally compared to the proximal pressures. So if you're getting really, really high pressures in the ankles compared to the brachial pressures, you can bet that it's calcified. Okay. So some advantages of pressure evaluation is that it's quantitative information, it's easy to do, and it's been clinically validated and correlated, so it's pretty accurate. Okay, so switching gears, now we're gonna talk about PVRs. So basically you're gonna position your patient, you're gonna apply the cuffs basically in the same way that you would do for a 3 or a 4 cuff segmental pressure. And then you're gonna obtain PVR waveforms. And the last part is we're gonna interpret and decide what's normal or abnormal. So, you guys remember plethysmography, right? Pulse volume recording. So basically it records changes in volume in that limb that you're recording for each cardiac cycle. So it uses pneumatic sensor cuffs to measure blood volume changes, and it's going to convert cuff pressure into an analog waveform, which is the pulse volume recording. So we can also use photoplethysmography or PPG, and we just talked about PPG. It's going to detect cutaneous flow and record those pulsations. Okay, so as a refresher, PVR, during the evaluation, blood is forced into the leg during systole, like so, and the girth of the limb is going to increase because of the increase in blood volume during systole, and so the air in the segmental pressure cuff is going to be temporarily displaced, and that's what creates this upstroke on the waveform during systole. So this is systole. So systole, the arterial pressure is high, blood volume displaces the air in the cuff. During diastole, the arterial pressure is low, that waveform is going to come down. A normal waveform should have a sharp systolic upstroke, and a dichrotic notch, which you can kind of see here. Okay, so for PVR, you're going to place your patient supine, just like for segmental pressures. Put the cuffs on the same way you would for segmentals. The cuffs are connected and sequentially inflated to a specific air pressure, which is around 65 millimeters of mercury plus or minus 5. You're not trying to obliterate the signal for this purpose. So you're just trying to get waveforms. The patient needs to be still because you can have some sort of motion artifact kind of, in your signal. You don't want that. You're going to record the PVRs for each limb segment. Set the gain or the scale adequately to enlarge the signal so that you can do your waveform analysis later on. You can make a normal waveform look abnormal with a low gain setting, so be aware of that. But you can't make an abnormal waveform look normal, and we'll see in just a minute. So, when you get your tracings, this is what a normal PVR waveform is going to look like. So, waveform analysis kind of assesses the contour of the waveform and the amplitude of the waveform, how tall it is and what this peak looks like, basically. So, this short arrow here is pointing to peak systole, and you can see that it is a sharp upstroke. This longer arrow is pointing to that dichrotic notch that we talked about, which represents the closure of the aortic valve. So a normal waveform has a sharp peak, tall amplitude, and a dichrotic notch. So when you're interpreting your PVRs, The PVR is gonna reflect the volume of blood coming into that cuff segment. So an abnormal PVR at the thigh will indicate inflow disease. More rarely, though, it can indicate profunda disease, deep femoral artery disease. If the thigh PVR is normal and the calf is abnormal, the disease will be in the SFA or the popliteal, somewhere between those two cuffs. So for PVR, disease proximally will affect all of the waveforms of all of the segments distally, because flow will be compromised distally because of the stenosis. Does that make sense? So proximally, if you have a stenosis, it's going to affect all the waveforms distal to that. Calf PVR might be higher than the thigh and the ankle, and that's due to variations in the limb girth and the cuff size and the air volume within the cuff. Normal thigh and calf PVR with abnormal ankle recordings means that you have some sort of tibial disease present. So PVR is just kind of like a subjective assessment of overall limb perfusion. PVR is not affected by calcified arteries, the way segmental pressures would be. And it's easier to do than continuous wave Doppler. So that's PVR in a nutshell. Okay, so let's look at what the waveforms mean. So normal, you're gonna have that sharp upstroke. You're gonna have this prominent dichrotic notch here in late systole, early diastole. So with mild disease, you're gonna start to see this waveform broadening, so it's gonna kind of become wider here. You're gonna lose that dichrotic notch. It's not gonna be there anymore. And you're gonna slightly lose some amplitude as well. So for more moderate disease, you're gonna notice that this peak is gonna start to round out. It's gonna become rounded. Again, no dichrotic notch, and an even bigger decrease in amplitude. So this waveform is getting shorter and shorter. So for severe disease, you're gonna have very low amplitude. It may also be flatlined if the disease is actually that bad. Very, very rounded peaks and just slow upstroke there. Okay. So some limitations to PVR analysis. With severe proximal inflow disease, PVR is not accurate in predicting whether there's distal disease, right? Because that proximal disease affects all of the waveforms that come behind it distally. So that's kind of a big drawback with PVRs. You need the patient to cooperate to avoid motion artifact. That can be kind of hard in certain situations. The waveform assessment that we just looked at is pretty subjective. So you can have a lot of inter-observer variability, and it's not really quantitative, so it's really subjective. PVR amplitude is not really that reliable a way to determine the level of disease, like from mild to moderate to severe, or the presence of disease either. There's just too many factors that can affect the amplitude of the signal, from one segment to the next, or from the same level on the contralateral leg. So, how snug the cuff is around the leg can actually affect the amplitude as well. So just make sure that your cuffs are snug. So those are the limitations. The advantages of PVR, however, it's very easy to learn, very easy to do. It gives you an overall assessment of global perfusion of that limb. You can do toe evaluations, which is not usually affected by calcification. Those are the pros. Okay. So now we're going to talk about Doppler waveform analysis. So this is where we're going to record continuous waveforms. We're going to position our patient. We're going to get those continuous waveforms. There's different sampling sites we're going to talk about, and then interpretation of waveform morphology. And then we're going to talk about some nomenclature issues. Okay, so procedure, basically the same. Patient supine at rest. You're going to take your continuous wave Doppler probe and position it on the common femoral artery just below the inguinal crease of the leg. And you're going to angle it at 45 to 60 degrees up towards the patient's head. Try and find the center of the artery, which will give you the strongest signal. So you want audibly the strongest signal. If you're getting too much of the venous signal interfering because you know the artery runs with the vein, try a different approach. Try going more medial, try going more lateral. You need to maximize your gain and the amplitude. So we're getting waveforms from the common femoral, the superficial, proximal, distal, the popliteal, the PTA, and the DPA. And then you're going to repeat it for the other leg. So that's basically what we're going to do. So there's two ways that the continuous waveform is going to be displayed. There's an analog display, which uses a zero crossing detector, analog Doppler. And so it's just going to give you like a single line tracing of the average velocity. So this is analog here. It's just a single line tracing of the average velocity. And the second way that it's going to display is fast Fourier transform. And basically it's a spectrum analyzer that has full spectral capabilities. So it's closer to what we see when we're doing a duplex spectral exam. This method is less prone to averaging the venous flow with it. That's within the V path. So it's not likely that it's going to average the venous flow within this arterial signal. Okay, so Doppler waveform morphology is assessed using three different characteristics. We're going to look at pulsatility of the waveform, systolic forward flow, and early diastolic reverse flow. So, looking at this normal or multiphasic waveform, which we know as triphasic because it has 1, 2, 3 phases. You're going to have a sharp systolic upstroke, an immediate drop of the waveform below the baseline, and then a small little blip of amplitude before the next systolic peak. So that's your normal triphasic waveform. So when you have moderate disease, so this is abnormal moderate disease here, you're going to lose that triphasic waveform. So you're losing phasicity. The amplitude, again, is reduced. And then you're going to start to see this rounded peak here. That's moderately abnormal. So for a severely abnormal scenario, you're not going to get any kind of triphasic waveform at all. It's monophasic at this point. Amplitude is extremely low. You're going to have this delayed upstroke to the peak. Monophasic and low amplitude for a severe disease waveform. Okay. So Doppler waveform analysis is, again, pretty subjective. It requires a lot of skill and experience. The bottom line is that you're looking for loss of this triphasic waveform, a dampening of the amplitude, a slow upstroke, and a rounding of that peak. And so that's basically how we're going to differentiate mild to moderate to severe disease. The problem, though, is that most clinicians are moving away from like triphasic versus biphasic because it's confusing to a lot of people and it's very subjective. So the trend now is to use multiphasic to describe these waveforms. So triphasic is now multiphasic. What was considered biphasic is now multiphasic. So we're going to use multiphasic for signals that aren't like obviously monophasic. Because look, some people may call A biphasic. B, some people may call this biphasic as well because it's above the baseline and then you've got this diastolic flow. Or some people may call this monophasic, which A and B are showing two different flow patterns. Like this is almost a triphasic flow pattern, and this is just forward flow throughout the cardiac cycle. So it's super confusing. So we're just gonna go with multiphasic for these two scenarios, and then monophasic for an obviously monophasic signal. Any questions? Okay. And in clinic, you're probably still gonna hear triphasic, biphasic, and there's gonna be a lot of like discussion as to what really constitutes triphasic versus biphasic versus a monophasic. So it's all very confusing. Okay, so some limitations to waveform analysis is that you can have a lot of artifacts in the waveform. You can have signal attenuation from obesity, scarring, calcification. Waveform analysis is not quantitative in any kind of way, so you can't really assess severity in a quantitative way with this. You can have venous flow interference, and the system will average the venous flow to the arterial signal. So it's not going to represent only an arterial signal. So you'd have to like somehow eliminate the venous signal by repositioning your probe. Medicare, which you might see a lot of Medicare patients, prefers continuous wave Doppler to traditional duplex ultrasound imaging. So on some patients, they might not be eligible for duplex ultrasound based on their insurance. Okay, so this is a continuous wave Doppler analog recording. On the left side, you can see that these thigh tracings are already monophasic. So what's that going to indicate? What does that indicate? Yeah, that there's inflow disease proximal to this segment here. And so it's going to affect everything below it. Also, the ABI here is 0.57. So that already tells you that there's issues here. Distal locations will be abnormal to inflow disease. So if the common femoral artery is abnormal, everything distal to that is going to be abnormal. Also, if you look at the high thigh pressure, on the right side it's 156, which is well over the systolic brachial pressure, but on the left side it's 96, which is already way lower than the brachial pressure, so you know you have inflow issues there. So, and this study shows you an abnormal right DPA, which is really monophasic, and the pressure is super, super low. So that's indicative of tubular disease. Alright, so when you're interpreting, look at the ABI first, see if it's normal or abnormal. You wanna make sure that the ankle pressures correlate with the ankle waveforms. So like if the pressures are normal at the ankle, the waveform should also be normal. If the pressures are low, the waveforms are gonna be abnormal. Determine the region of disease by analyzing thigh PVRs and pressures. Determine if there's multi-level disease versus single-level disease, and we'll go over through some scenarios as well. Determine the severity and if this disease is actually what's causing the patient's symptoms.
And for inguinal, how do you differentiate that between anglo and like femoral?
By the PVR waveforms. Yeah, the waveforms are gonna be different. Okay, so exercise stress testing. Let's talk about what it is, who's a good candidate for it, contraindications for it, how to do it, and how to interpret. Okay, so exercise stress testing is done on those kind of patients that complain of pain, claudication pain when walking. If they can walk, then we're gonna exercise these patients. If they have contraindications or they can't walk, then obviously we're not gonna do exercise stress testing or put them on a treadmill. Exercise stress testing helps to differentiate between true vascular claudication and pseudo-claudication, which it has non-vascular origins like neurospinal compression or something like that, diabetic retinopathy. It's something non-vascular that's causing these patients' symptoms. Some patients might have a normal resting ABI. So the resting blood flow could be good enough to maintain normal or close to normal distal pressures in the ankles. So exercising these patients might elicit the symptoms and reveal the presence of disease, because if you remember, when flow increases over a stenosis, the distal pressures will drop distal to that stenosis. So if a patient's symptoms happen at rest, which is not claudication, and the resting ABI is normal, then you don't need to exercise the patient, because we're only doing this with patients who have claudication symptoms, which usually happens during walking or some sort of exercise. Okay, so who qualifies for an ABI? It's gonna be those patients that have intermittent claudication. The ABI is abnormal between 0.85 and 0.5, which is the moderate range. These are the patients that have the normal resting studies, but they still have claudication symptoms, so they need to exercise to reveal that disease. You can also use this for patients who have kind of like a borderline resting ABI, and it helps to differentiate between a normal exam and an abnormal exam. Some contraindications to not put a patient on the treadmill is if their cardiac status is questionable or they have no cardiovascular disease, severe pulmonary disease, can't walk on a treadmill for whatever reason, ischemic rest pain, they're probably not going to be able to walk, ischemic limb ulceration, in patients with symptoms only at rest and a resting study that's normal, no exercise. Okay, so the protocol for an exercise stress test. You're gonna explain the test to the patient, explain what your expectations are, that they're gonna be walking on the treadmill for X amount of time. Usually it's 5 minutes, or until the pain gets so bad that they have to stop, and they're gonna have to let you know when that is. So ask them to tell you when they start feeling the pain, because you're gonna document that and how long they were walking before they experienced those symptoms. The location of the pain, whether it's in their thigh or calf or whatever, and the severity of the pain, how bad is the pain. Also, since we're gonna be stressing the patient and they're on a treadmill, ask them to report any cardiac symptoms like shortness of breath, chest pain, etc., because you don't wanna be exercising someone who's having active chest pain. It's just not a good idea. So we're gonna set the treadmill speed to 1.5 or 2 miles per hour at a 10% grade, depending on the patient's age and depending on their mobility. Maybe less, depending on those factors. But the standard walking time, like I said, is 5 minutes, or until the pain or other factors like the chest pain prevent them from walking any further. So you're gonna write down claudication symptoms, the location of those symptoms, how bad are those symptoms, the total walking time, and the onset of symptoms, okay? Then, once they're finished exercising, immediately bring the patient back to the bed as fast as they can safely do it. And this is when you're gonna get bilateral ankle pressures, and those systolic arm pressures again. So you're gonna use the pedal artery, either the PTA or the DPA, with the higher resting pressure, and you're gonna use the arm with the higher resting brachial pressure to calculate the ABIs. In patients with occlusive disease, the ankle pressures are gonna drop, and that's what you expect to see in those patients. Once you stop the exercise though, the pressure is going to gradually increase, and you're gonna get post-exercise PVR or Doppler waveforms in those patients. Okay, and so then you're gonna calculate the post-exercise ABI. So there's two different ways that you can do this. The first way is just the normal way to do it. You're gonna get pressures in both ankles, pressures in the arms, use the highest arm pressure, and then you're gonna calculate one ABI for each leg. The second method is you're gonna get serial ABIs for 5 to 10 minutes after exercise or until the pressures return to baseline. Post-exercise ankle pressures of 60 millimeters of mercury or less confirms that the pain the patient is experiencing is due to vascular disease. So, this is important to know. Okay, so, like I said, some labs record the ankle pressures at 1 to 2 minute intervals for about 10 minutes after exercise or until the pressures return to baseline. A longer than normal recovery time suggests the presence of multi-level disease or poor collateral flow. So this graph shows that the patient exercised for almost 3 minutes when their symptoms started, and so they stopped at that point. The ankle pressures were already low before exercise. So you can see the brachial pressure here at about less than 140, and the ankle pressures are like less than 100 already prior to exercise. Once exercise started, that pressure dropped significantly, which is what we expect to see. And then it took about 6 minutes for the pressures to return to baseline. So that's a pretty long time. So this is the graph that they kind of plot that information on. Okay, so interpretation for exercise stress. Some normal patients can have a mild transient drop in pressure right after exercise. while other normal patients will maintain a normal ABI. However, patients with arterial occlusive disease will have a drop in pressure. Now, how much of a drop depends on how severe their disease is and the amount of collateral flow they have distally. A large drop in pressures and ABI means that disease is present. Immediate post-exercise ankle pressure of 60 millimeters of mercury or less confirms a vascular cause for that patient's symptoms. Vascular etiology for the pain is not likely if immediately post-exercise the ankle pressures are well over 60 millimeters of mercury. So in those patients, if pressure is over 60, then the cause of their pain is likely not vascular. Ankle pressures are going to start rising as soon as exercise stops, so don't wait too long to get those pressures, or the resulting pressure will be erroneously high. So you want to get those pressures as immediately as possible once they stop the treadmill. So some patients can't walk, so we have to find different ways to test these patients, and one of the ways is post-occlusive reactive hyperemia. So it's a substitute for the treadmill in patients who can't walk. So basically, it mimics the physiologic response to exercise by causing vasodilation in the vascular beds of the skin and muscle. Because those vascular beds are deprived of blood flow, so they dilate in order to receive more blood flow. So you're gonna inflate a cuff that's gonna act as a tourniquet. Once the occlusive thigh tourniquet pressure is removed and you start bleeding out that pressure, the blood flow volume to the leg is gonna increase dramatically. So flow across the stenosis is gonna increase, and if it's significant, the stenosis, the distal pressures are going to decrease. So the procedure is you're gonna get a resting ABI first. Then you're gonna apply your blood pressure cuff to the thigh. You're gonna inflate it to 20 millimeters of mercury over the thigh pressure, or 40 millimeters of mercury over the brachial pressure. So whatever the resting thigh pressure was, 20 over, whatever the resting brachial pressure was, 40 over. You're gonna keep that pressure applied for 3 to 5 minutes. That's a long time. Probably painful too. Then you're gonna release it and get the ankle pressure. So in normal patients, you're gonna get little to no pressure drop because there's no stenosis there. A pressure decrease of 20 millimeters of mercury or more suggests the presence of disease. This test can uncover the presence of disease that may not be obvious at rest, and differentiate between borderline normals. Okay, so this test usually is not well tolerated. It's super painful for the patient, they don't like it. While it can uncover hidden disease, it's not really great at differentiating true vascular claudication from pseudoclaudication because the patient's not actually exercising. You can apply the tourniquet to the calf versus the thigh to kind of alleviate some of the pain. That's only okay if the disease is below the common femoral artery, and only like in that femoral popliteal tibial segment. So there's some limitations here. So toe raises is a more patient-friendly alternative to the treadmill and to reactive hyperemia. So toe raises are done with active plantar flexions, which is also called heel raises. So you're gonna get baseline pressures first with the patient supine. Then the patient's gonna stand and they extend both feet fully and then relax and return their feet flat to the ground at 1 second intervals. They're gonna do toe raises 50 times or until the patient can't continue going because the pain's too much. Record the patient symptom onset and the number of raises done at the symptom onset. You're gonna get immediate post-exercise arm and ankle pressures. Again, a pressure drop of more than 20 millimeters of mercury or a decrease in the ABI calculation of 20% is abnormal. The limitations of toe raises, it doesn't actually reproduce the patient's ischemic claudication symptoms, because it's not using the same muscle groups that you use when you're walking. So patients can have a mild vascular disease and a slight drop in pressure after toe raises, but the calf pain might be to fatigue, not necessarily claudication. So you need to correlate claudication symptoms with a significant pressure drop to confirm that it's actually a vascular problem that's causing those symptoms. It's not a great substitute for the treadmill for these reasons, but you know, in patients who can't exercise, this is an option. Okay, so let's go over some cases. So, putting everything together. So this is an example of a complete bilateral, non-invasive study with PVR. So it's this is the Ford cuff method. What's the first thing that you're gonna look at? Anyone? What's that? So the first thing you wanna look at is the ABI. Is it normal?
Pretty
Is it
close.
abnormal?
Pretty close to normal.
Yeah, I would call this normal.
We're just going off your stats earlier.
Yeah, we're going off those stats. Anything over 0.9 usually.
Asymptomatic, maybe normal. Is
What's that?
That's what it was, right? Asymptomatic, but maybe normal
Yeah.
is what it was.
Yeah,
listed
there's no symptoms. So then we're gonna look at the waveforms. Are these waveforms normal? Do they look normal to you guys? Yeah. So you've got a tall peak, high amplitude, you've got this dichrotic notch. These waveforms are normal. Let's look at the thigh pressures. Are the thigh pressures higher than the brachial pressures? Yes. That's what you expect to see with that high thigh cuff, right? So yeah, this is an example of a normal forecuff segmental pressure with PVRs. So those are the things you want to look at is the pressures compared to the brachials, the ABIs, and the waveforms. Okay. This one. So this is an example of a continuous wave Doppler study with waveforms. So first off, how's the ABI? Yeah, normal. Okay. What about the waveforms? Looks good? Triphasic all the way down? So yeah, this is another example of a normal study. And so the thigh pressures, what do we think about those compared to the brachials? It's higher. So is that normal? Yes. So what can we tell already? That there's what? No inflow disease? Okay, so either there's no inflow disease or mild inflow disease. What about the toe ABI? You got 0.79 on the right side and then 0.87 on the left side. Is that normal? Yes, because it's greater than
10?
0.75. So that's a normal continuous wave Doppler exam. So that's what it's gonna look like. Okay. So Case 1. This is a 35-year-old male with acute onset of right calf claudication. He's got no symptoms in his left leg, okay? He's got a history of aorta to right common femoral bypass. That's important. They palpated the pulses on this patient from the common femoral, the POP, the DPA, the PTA. They were all 0. What does that mean? They couldn't feel a pulse, right? Okay. The left side, all the pulses were 2+, which is normal. So, the left side, how does everything look over here? ABI is 1.2. Normal? Waveforms? Normal. Okay, so the brachial pressures were 100. The left high thigh is 140. That's normal, right? So what about this right side? What's going on here? Yeah, it is monophasic. So what does that tell us? Where is this occlusion? Yes, it's proximal. So because he had that history of that aorta to common femoral bypass, his native artery is already occluded. We know that. So they put that bypass in place to bypass the occlusion. So because these PVRs are abnormal, we can kind of infer that something's up with that graft, right? So they weren't able to get pressures in the right leg at all. They didn't find any flow that was detectable